Modalities, ultrasound, and electrical stimulation are the primary modalities on the exam. And electrical stimulation can be used a lot of different ways. And we sort of got to think about what we were talking about last night with exercise, because electrical stimulation sometimes causes exercise of the muscles. So let's start off with thermal modalities, or therapeutic modalities. In all, there's a frequency that the treatment needs to be administered in, like 2 times a week, 3 times a week, 4 times a week, etc. There's the intensity of the treatment, which can be changed. That's a parameter you can change always. And the duration of the treatment plan, how many weeks you're going to continue that treatment for. So you got frequency, intensity, and duration of the actual treatment. Now, the specific treatment, there's also going to be frequency, intensity, and duration of the treatment session as well, which is slightly different and will vary as to the modality you're using. Forget about contraindications and indications. They don't use that terminology as far as writing exam questions anymore. You will find it in O'Sullivan texts, but you will not find it actually on the exam. I like the word precaution better than contraindication and cautions, because when you have a precaution or a caution, you always want to think, why can't I do it? What is this modality going to cause that I don't want it to cause? And it's taking you another step. Typically on the exam, as we have seen, they're taking it one more step than what you probably had in school. You want to understand why the modality is affecting different types of tissues. You really want to know, because modalities change the physiology, and that's important. So you really need to know, to select a modality, you need to know why it would be cautioned or beneficial from the physiological level of the patient, because they really change a lot of the physiology. Thermal modalities, probably the most often used. It's really introducing a different temperature. You can have either cryotherapy, which is cold, or you can have heat. And heat, we're talking here superficial heat. And you can do a superficial heat and a deep heat too. If I'm doing both, I'd want to do the deep heat first because the tissue is a little firmer, like it'll draw the ultrasound down better to your target tissue that you're after, and then the superficial afterwards. If you did superficial first, it loosens up the skin so much as a lot of that ultrasonic energy may actually be absorbed by the upper layers of the skin and not get to where you want to target it, or the upper layers of the tissue, and it may not get to what you're targeting. Hot versus cold. They both initially cause vasoconstriction. If you touch a hot stove, bring your hand back and look at it, it's going to be white where you hit the stove. And white-colored skin is vasoconstricted. In about 3 to 7 minutes, vasodilation is going to kick in. Now, the body doesn't really sense whether it's heat or cold that much. It senses the intensity of it, how far it is away from normal body temperature. That intensity is what triggers all this. The vasoconstriction is actually from a local neurological response. Not even spinal. It's more local than even spinal level. There may be some spinal level too, and the idea of vasoconstriction is to prevent fluid loss and prevent things getting into the body itself as well. It basically walls things off. About 3 to 7 minutes later, in somebody that doesn't have a lot of disruption of their vascular system, there's hormones released from the irritated or damaged tissue, like kinins. They go through and they're going to cause an inflammatory response coming back. And that causes more vasodilation. And it really overpowers the vasoconstriction. So vasoconstriction remains there, but it can be overpowered by this hormonal effect. But you got to have good circulation to get the hormones from the tissue to their targets and then the response coming back again. So you have to have good circulation for that. Heat decreases local nerve conduction velocity, but doesn't do it very much and it doesn't last very long. Maybe 20 minutes or so post-treatment, you'll still have somewhat of slowing of nerve conduction velocity, which means patients won't feel things as much. They'll feel things, but not as finely as they normally would. So it decreases their pain. It sometimes allows you to conduct another treatment during that 20-minute window. It also increases local metabolism. So tissue will heal faster, but it's also going to cause the tissue to actually require more oxygen and nutrients as well. It increases the tissue compliance. The tissue just gets softer. Connective tissue loosens up, and that's going to allow like edema and things like that to collect in the interstitial spaces more. But it also allows fluid to move better as well. So you can sort of counteract that by either compression or elevation. But tissue is fairly soft when you use heat. When you use cold, you actually decrease the local metabolism. The tissue isn't demanding as much oxygen. Those things are occurring. It decreases the tissue compliance, so the tissue won't expand to allow a lot of infiltration of edema in the area. So it actually prevents edema from collecting in the first place. That's why we use it for acute injury. That's one of the big reasons for acute injury are those two things. You want to drop the metabolism rate to allow the vascular system to regrow to the area, to reoxygenate it, provide nutrients to the area as well. Because if the area runs out of oxygen and nutrients, you get avascular necrosis happening. It delays that fairly significantly. It also prevents edema. It also decreases local nerve conduction velocity fairly significantly. And it may have, now we're talking 4 to 8 hours of decrease in nerve conduction velocity. So this is going to last a lot longer. It's going to take pain away a lot more than heat would, and that's another good reason for using it for acute injury. Although there's a little bit of debate whether or not we should really take all the pain away from our patient, because pain is telling the patient not to do things. So it may actually be sort of good. Cold decreases local cellular transport, whereas heat increases the local cellular transport. And that obviously heat would increase the local perfusion. Cold basically decreases the local perfusion, but it may increase some distal perfusion to try to rewarm the area up. If you've done an ice massage on somebody for about really anytime over about 7 minutes to 15 minutes, they'll start feeling not cold anymore, but they'll feel a gentle warmth to it. Heat, we really can't get over 120 degrees. Over 120 degrees will cause tissue damage, particularly if you have really good conduction like water. If you have air, it doesn't conduct the temperature as much. So like fluidotherapies run 122, 125 degrees. And you can get away with that dry heat that way, which doesn't conduct a lot of the thermal energy as much. We really use a lot in subacute conditions, where cold is used in the acute condition, the first 48 to 72 hours after injury. Heat, after about 48 to 72, they're starting to get in the subacute phase, and you can start using more heat. Another way to tell they're in the subacute phase is the skin will get red or pink up and get a really reddish tone to it. And that tells you you're getting into the subacute phase instead of the acute phase. And increasing the local perfusion, increasing the cellular transportation, and increasing the local metabolism really may cause things to heal a little bit faster. That's always questionable because healing has a lot of factors that go to it, but this covers some of them. The intensity of the stimulus is important. Normal body temperature is about 98.6 degrees Fahrenheit. You may want to know what that is in Celsius as well for the exam, because they sometimes give you it in Celsius. Most of the time, we see temperature more as degrees still. That's one thing that hasn't gone metric very easily. And the conversion between Fahrenheit and Celsius is really a fairly difficult mathematical conversion to make. Not that easy. I would sort of memorize typical temperatures in both Fahrenheit and Celsius to get ready for the exam. The change in the tissue temperature takes it away from the normal temperature, initially causing a local neurostimulus, because the skin doesn't know, or the body doesn't know what happened to it. It knows something's happening to it, so it starts walling everything off. The greater the change from normal body temperature, the greater the amount of stimulus you have, thus the greater the response. High heat is like 105 in a whirlpool. 120 can scald you and cause tissue damage. So it's somewhere in that 104, 105 degree area we usually use for hot. With hot packs, they come out a lot hotter, but you're supposed to put about 6 layers of toweling between the hot pack and the skin to try to prevent the skin from getting burnt. Because if you put a hot pack right over the skin, it will burn it. It will scald it and cause at least a second, if not a third-degree burn, usually second. Cold, on the other hand, you see tissue damage occurring with chronic use of cold below 45 degrees. You can actually start freezing the tissue and forming ice crystals at 32 degrees. So there's a lot more range going down. Cold whirlpool at 45 for 20 minutes is okay, but you wouldn't want to leave them in there for an hour. That could possibly cause some tissue damage when you're starting to get over that 20 minutes. Why 20 minutes? I don't know. It's just a convention that we typically use for some of our treatment times. So if you really want to take pain away, use cold, close to 45 degrees. That'll really take the pain away for about 8 hours. And it's probably more effective than even opiates as far as taking the pain level down. It's probably one of the most effective ways of doing it. And you could reapply cold about every 2 hours if you want to maintain the pain relief in a patient. You do 20 minutes every 2 hours. You want to be cautious if you're treating an anesthetic area or an area of impaired sensation. You can check that out with Weinstein filaments and things like that to get an idea of their sensation in the area. You can also use temperature, and if they can't feel the change in temperature at all, that's pretty anesthetic tissue as well. Another decision-making point is how much of the body am I going to treat? Large areas, even using a hot pack over the whole low back, could potentially raise core body temperature. You probably don't want to use that over about 10 minutes. It will cause vasodilation. That's going to drop your diastolic blood pressure too. That could have effects throughout the whole body. Smaller areas, less systemic effect on the body, because if you just do like the foot or something, you're not going to drop the body temp or raise the body temp significantly at all. Ice massage, again, is usually a fairly small area. You're probably not going to be affecting the whole body very much there. And there's deep heat. Primarily, I would say using ultrasound and concentrate on that one. You can use diathermy to do that too, because really the only positive effect of diathermy as far as a PT clinician goes is to cause a deep heat. So just to review a little bit, heat, it increases the local metabolism. You may actually have some perspiration as a result of it as well, because the body is going to be trying to cool itself, so it opens up the sweat glands and they start producing a lot. After about 5 to 7 minutes, you get histamine-like substances like the kinins and things like that that really overpower the vasoconstriction and cause that local vasodilation. And you usually see a red skin, which is the hyperemia. Initially, vasoconstriction occurs in even the deeper tissues, like the blood vessels that are supplying the capillaries up on between the epidermis and the top of the dermal layer, but just below the epidermis. It would induce some muscle relaxation and decreases nerve conduction velocity, which really decreases the background tone in the muscle. Our muscles are always firing a little bit, but not so much that it causes any movement at all. Unless you're totally paralyzed, those muscles are actually moving a little bit in there. A few muscle fibers will contract every so often, not enough to actually move an extremity or anything like that, so you don't notice it. But it does pump the lymphs, it does pump the veins. With mild heat, the sensory nerve endings are sedated probably for about 20 minutes. If a large part of the body is heated up, like hot packs over the whole low back and thoracic area or something like that, you just load them up with hot packs. You put them in a whirlpool of 105 degrees temperature. Then you're going to start raising the core body temperature as well, usually starting 15-20 minutes after you've started the treatment. The capillary permeability increases with it as well. So fluid can escape into the interstitial spaces more, and they're all looser, so they can absorb a lot of that fluid, so you're actually getting fluid in the interstitial spaces quite a bit more with doing this. So elevating the portion of the body that you are heating up may actually counteract that edema and prevent edema collection. And you got about 20 minutes of an effect post-treatment. Now, like scar massage, cross-fiber massage, myofascial release, and even stretching, heat alone makes the tissue more compliant, which means maybe some of the collagen fibers in the connective tissue that aren't oriented correctly, you can tear with your manual technique easier, but the ones that should be there are more preserved. So your stretching is going to really gain the range of motion you want in the direction, but not necessarily damage other tissue that you didn't want to damage. Hot packs, most common way to do conductive superficial heat. You can do a hot whirlpool as well. It's going to have relatively the same effect. You obviously want to remove clothing and jewelry in the area because that can retain the heat and really overheat right underneath it, possibly causing a skin problem. You really want to prevent that dependent positioning as you're heating them up. So elevation is important here. They should feel a gentle warmth. Usually use an insulated hot pack, which is about 6 layers of toweling, or the hot pack covers give you at least 2 to 3 layers right there, actually 2 to 4 layers right there, so maybe a towel over it, doubled, and then the hot pack inside one of those hot pack sleeves gives you that adequate protection. Give the patients the adequate protection. That 6 layers of toweling I find in most reference sources, so I would sort of concentrate on that more. In the clinic, though, those hot pack covers are awful easy to use, but you should have at least 2 layers of toweling underneath that as well. You need to monitor a patient. You need to come back in really after about 5 to 7 minutes, peel it off, look at with the skin color. It probably should start causing redness of the skin. You should always be talking to your patient where the heat is uncomfortable or not. Dark red would probably indicate there's too much heat, and modeling can occur for a couple reasons. The most common reason is the local area has run out of hormone to be able to be released, thus it goes back into vasoconstriction. So you end up with these little white dots on sort of a red background. Also, too, it could cause the capillary beds to become hyperpermeable, and that could allow some blood to actually leach out of the capillaries into the skin, basically tattoo the patient, which you don't want to see happen. That happens if you leave heat on 45 to 60 minutes without removing it, and it remains fairly hot. Preheating, sometimes it will enhance electrical stimulation because it decreases the skin resistance to the electricity. So it allows you to have more of an effect from the electrical stimulation with less irritation. So the patient will tolerate really a higher current density there. And electrical stim, current density is a major factor that causes all the factors of electrical stim. I'm going to say that many because you can use electrical stim to do many different things. Treatments are usually about 15 to 30, but if I'm just preheating somebody, probably 10 to 15. Paraffin baths also show up sometimes on the exam, particularly if you're doing a lot of hand therapy. It could be used for the foot as well. You dip the part of the body in the wax, and that wax is about 125 to 127 degrees Fahrenheit. 52 to 53 degrees centigrade. The mixture is 5 pounds of wax to 1 pint of oil. Now, oil and wax, they retain the heat more, but they don't distribute it quite as much as water would. They're not as conductive. So you can get away with a higher temperature there. Because that heat is not coming in as fast, thus not really damaging that much. After you've dipped them, I usually put a plastic bag over them just to prevent a mess, and then 6 to 10 layers of toweling over it, or hot pack. I can use hot pack covers as well. One hot pack cover is worth about 3 to 4 layers of toweling. That insulates it. It keeps it hotter for a longer period of time, allows the treatment to be more effective if you do that. And you probably leave it on them for close to 20 minutes. It really gets into small areas, as I said, like the foot and the hand. It get all the way around the fingers, get all the way around the toes, things like that, where a hot pack wouldn't. You could use a whirlpool and probably get about the same effect, or a fluidotherapy. There are some insulating gloves you can get, which again provide several layers of toweling there. Hydrotherapy we're not using that much anymore, probably because it's, number one, very expensive to use. You also have a risk of cross-contamination a lot more. Now, with the wax is, you have the patient dip their hand in the wax about 3 times to get a good coating of it, but then after treatment, that wax that is in contact with the patient should be disposed of. It shouldn't be put back into the wax heating unit. I know it's done in the clinic sometimes. It shouldn't be done because it's going to take contaminants from one patient to another and cause some cross-contamination going on there. You want to prevent that. Did their hand in wax, I really want to keep it elevated so I don't cause edema. Water also contains bacteria in it. There are additives sometimes we add. Bleach is a really common one to try to kill off the bacteria within the water so you don't have as much cross-contamination going on. And even if you clean your whirlpool out pretty consistently, still around the drains and stuff like that, some bacteria may start to be in that nice, moist, damp area and start to grow and actually increase the risk of infection to another patient. So the use of that. Using a whirlpool, you should initially fill the tank, add your additive as you're filling it. So the additive is there. Run the agitator for about 5 minutes or so. So all your decontamination chemicals are spread out nicely throughout the water. Those chemicals, though, are cytotoxic. In other words, with wounds, they will be toxic to the wound itself. Water by itself, if you have an open wound, is toxic as well because the cells will actually try to equalize their electrolytes inside the cells to the external environment, and a lot of water will actually flow in, actually basically burst some of the more superficial cells and cause more tissue damage that way. That's one big reason they're not used. It just would not be cost effective to use like saline, which is an isotonic solution for like a foot tank, or definitely not a Hubbard tank where the whole body's in it, or a therapeutic pool. Therapeutic pools use chlorine and things like that like you would in a normal pool, trying to prevent the cross-contamination. You don't drain those between each patient. Foot tank, hand tank, even Hubbard tank, you're filling it just for one patient. Then you're going to drain it. Then you're going to scrub it down with a decontamination solution. Fill it back up. Run the agitators so that decontamination solution gets into the agitators as well. Kills off a good portion of the bacteria. Probably should let those agitators run for about 45 minutes. Then drain the tank again, and then rinse it with cold water. That's going to probably decrease the bacteria count right then and there, but bacteria is in the air and things like that, so if you don't use the tank all the time, it's going to become contaminated just being there. If you haven't used the tank in a while, you probably need to clean it before you put the patient in it and go through this cleaning procedure. When the foot, like a foot tank or a Hubbard, the part of the body that's actually under the water is heavy, puts an external pressure on the skin. That's transferred down in the body. It actually may raise the diastolic blood pressure in the patient. Like a Hubbard tank, I'd be really cautious using it with somebody with congestive heart failure, for instance, because it's going to raise that diastolic pressure, put a lot more stress on the heart. Whirlpool, the same thing, or a therapeutic pool. The deeper they are, the more pressure they have on them. That pressure would prevent edema from collecting. So the area underneath the water, you're probably not going to collect edema. But if you took the foot right out of the tank, for instance, and put it on the floor in a dependent position, and it's all nice and warm, it'll really swell up. Now, if you took them out and then elevated the foot, you probably actually would decrease the amount of edema in the area. And the effective positioning is quite great. With therapeutic pools, the deeper they are, the more the body that's in the pool, the more buoyancy you have. So it's really taking the body weight off the patient. You can sometimes get patients walking inside a pool where they can't walk outside of the pool because you have decreased the body weight maybe half or less, depending on how deep they are. And you'd actually progress the patient from the deep end with a lot of their body underneath and a lot of buoyancy. And as they get stronger, you start getting shallower and shallower and shallower. So the less the body is in there, the more body weight they actually have to be able to deal with. So I may start them in the deep end and work them towards the shallow end. There's some studies on use of therapeutic pools that have shown it's difficult to get much of a carryover. Same thing is true with the overhead supports. You might put somebody in this overhead harness to decrease some of their body weight and take some of the body weight off with the harness, trying to get them, and then you gradually decrease the amount of force you have pulling them up. Thus, the body has to overcome that additional body weight as they improve. Again, there's not great carryover with those. The studies have indicated that. I think you can get some carryover, but it's going to be sort of difficult to do, and it's a very gradual process. Anybody with open wounds and things like that, they can go into a sterile whirlpool. You would not want to put them in a therapeutic pool just because of the increasing skin damage that would occur and the risk of infection. Here's a chart with the typical use of temperatures. I would say very hot, I would know for the exam. Neutral is core body temperature. Cold to very cold we use a lot. Very cold, usually 1 to 5 minutes. Depends how much of the body is being involved. Now, ice massage, obviously, you're doing a very small area of the body more intensively. When you do an ice massage, the ice isn't always in contact with the same area of skin. So you have probably a 10 to 15 minute type treatment there. Ice massage is very effective in relieving pain. But the hydrostatic pressure, that's the pressure of the water, the deeper you are, the more hydrostatic pressure you have. And that would actually prevent the foot swelling up when it's in the foot tank. Now when it comes out of the foot tank, as in a deep hand position, it'll swell like mad if you did a warm whirlpool. The cold whirlpool, you've tightened up some of the tissue, it won't swell nearly as much. The hydrostatic pressure, if a lot of the body's underneath the water, like a Hubbard tank, which the whole body is in it, you could significantly raise your diastolic blood pressure. Now, a foot tank, no, but a Hubbard, definitely. A low boy or a high boy type whirlpool. High boy is like a hot tub. Low boy is like a bathtub. There, the body isn't really, well, low boy, the body really isn't that deep in the water, so the effective blood pressure there, probably fairly minimal. High boy, the body, a good portion of the body is like several feet below the water level. There you could definitely see an increase in diastolic pressure. Hot tubs can do that too. As I said, the high boy is like a hot tub. Agitation, that's this part over here, comes down in, there's an agitator there that blows the water at a certain force, usually below about 6 pounds per square inch. It's really not enough to remove any adhered tissue, but very loose tissue or very loose contaminants that will wash out. And sometimes you got a patient with a big road rash, or I've used low boys sometimes with patients with sacral ulcers that had a BM underneath the dressing and got into the ulcer itself. It's a good way to clean that out if it's a very large area. Really small area, pulse lavage is probably a better way to approach it. But if you have a lot of fecal contaminants and things like that, the low boy is probably a better way to address it. It also breaks up thermal gradients, because if the water just would sit against the skin, the water right next to the skin will start being the same temperature as the skin, but not the higher temperature of the other water around. If you circulate the water more with an agitator, you're constantly providing more heat and breaking down that thermal barrier as much, which makes it a lot more effective. The pressure there is enough to improve the lymphatic flow a little bit. Maybe something you might want to consider using before you do a lymphatic drainage on a patient. You also want to make the tissue softer so that you can palpate the lymph nodes better. The tissue is more compliant, so you can squeeze that fluid out of the area easier with the effleurage, and it makes your treatment more effective. Most of the time we use modalities to make our manual techniques more effective. Oftentimes on the exam, they'll give you a couple answer choices that would be purely manual techniques, and then some of the other choices may be a modality plus a manual technique. So you have to have best manual technique there and the best modality that would increase the effectiveness of your manual technique. And that's probably the best answer choice. It would be the modality plus the correct manual technique. The correct modality and the correct manual technique. Hubbard tank, is huge. It looks like a butterfly. And you can do range, they were made to do range of motion inside of them. There's at least 2 agitators. I've seen them up to 6 agitators in there. There's a headrest where the patient's head sits. Their body's out here. You can do ab and abduction, flexion and extension of the legs. You can do range of motion of the shoulders up here. We use these a lot when I say 60s, 70s, 80s. These are huge. They contain a lot of water, so you're using a lot of hot water to both treat the patient and a lot of hot water to clean them, and they take quite a long time to clean, and that's probably one of the big reasons we don't use them. And that hot water gets to be expensive, and the amount of therapist or aid time to be able to clean the tank afterwards is quite extensive. Ultrasound, the effect is where the ultrasound is aimed. It's not throughout the whole body, it's where it's aimed. So if I do it like mid-thigh here, I'm not going to really have much effect down here, and I'm not going to have any effect throughout the rest of the body either. I'm just going to have effect in the local area, and it depends on the BNR of the sound head. Low BNRs tend to be more of a cone shape. Down there tend to be more focused. Low BNR tends to be a high or a wide area and really wider than the tip of the sound head. Usually low BNRs are a little bit better machine because you can aim it better. Whatever you can set in a machine may be part of an answer choice, and they're looking for you to know the settings. The sound head has frequency to it, and that really affects the depth of penetration. 1 megahertz through average tissue penetrates about 10 centimeters, which is fairly deep. If it's mostly adipose tissue, it'll even go deeper because the more oily substances in adipose tissue really conduct the ultrasound better than any tissue that may contain a little bit of air to it, like muscle tissue that has oxygen in it and more gases. Fat has almost no gas to it at all, which allows it to penetrate a little bit further. Doing it over the buttocks or something like that where you have a big fat pad sitting there, you're probably getting close to 15 centimeters in depth with a 1 megahertz head. 3 megahertz heads are the other ones that are commonly used. The intensity causes different physiological effects, and there's typically high intensity and low intensity that we use. The high intensity has been around a lot longer in use, and primarily in the US and the Netherlands, we use ultrasound for the deep heat effect, and that you get with high intensity ultrasound, which is over 1.5 watts per centimeter squared, so somewhere between 1.5 and 2. Low intensity is below 0.5 watts per centimeter squared. England and things like that, they were using ultrasound a lot to really slow nerve conduction velocity, and you get a lot more pain control because the nerve conduction velocity is decreased if you use a low intensity ultrasound, and really a lot longer lasting. A high intensity will decrease pain, but again for about 20 minutes post-treatment. Low intensity ultrasound, you may have 4 to 8 hours of pain relief from it. There's pulsing of ultrasound, which reduces the intensity because like a 1-to-1 pulse, you set it for, now I'd never do this, but you'd set it for say like 1 watt per centimeter squared. That 0.5 to 1.5 is an area you really shouldn't use. But to make the math simple, let's say 1 watt per centimeter squared. What you're actually delivering to the patient, if you have it set at 1 watt per centimeter squared, is 0.5 watts per centimeter squared to the tissue on a 1-to-1 pulse, because it's on one and it's off one. So you're delivering about half the intensity the machine is set for. A lot of machines are 3 to 4, 2 to 3, things like that, where it's on for 2, off for 3. You're decreasing the intensity a lot. Some modality books that really probably aren't very good may say for acute conditions you use a pulsed, and really what it's doing is not creating deep heat, but it's more affecting the patient's pain level. You will get a little bit of cavitation with even low intensity ultrasound, but you're going to get a lot more cavitation with a higher intensity ultrasound. You're also, they think you are vibrating the tissue interfaces, and that's what's creating the heat at a high intensity. There's 2 types of techniques. There's constant ultrasound. Use it for delivery to a large area. You're moving the sound head at about 5 centimeters per second type thing. You may be doing a 5 by 5 centimeter area.
with it, and that's more the way to do a constant, and the sound head's always on there. Stationary technique, you're holding the sound head in one spot. You have to pulse it when you use the stationary technique because the ultrasonic wave will penetrate the skin probably deeper and deeper, possibly irritate the periosteum of the bone, which is really a very severe pain to a patient. Probably not really causing much tissue damage. Some books indicated that. I don't think too many patients would tolerate you doing that long enough to really cause tissue damage unless the area is totally anesthetic. If they're anesthetic, yes, it could, but otherwise you probably are not going to cause anything like that. But if you pulse it, the wave of ultrasound comes down, reflects back out again before the next wave comes in. If you didn't pulse it, the wave would come down, start reflecting back, hit the periosteum and start of the bone, start reflecting up, get hit with another wave, and distribute a lot of the energy more superficial than you probably want. And gradually, the longer you keep it there, the higher up it's going to be. So after about maybe 15, 30 seconds, you're just heating the skin right beneath the sound head and start to overcook the crystal of the sound head too and really cause a thermal burn on the surface. Embedded metal in a patient, if I just have a chunk of metal sitting there like a fragment of something like shrapnel or something like that, the ultrasound will actually vibrate the metal, so the tissue in front of the metal pretty much gets the same amount of ultrasonic energy as the tissue behind the metal. Now, if you have a pin or something in there, surgically implanted pin, it's going to vibrate the pin, and that could loosen up the pin. So it could loosen up a total joint, loosen up the prosthetic of a total joint replacement, things like that. So you don't really want to vibrate that because it could loosen it. This all making some sense?
Yes.
Yes.
Helping clarify things a little bit?
Yes.
Ultrasound is what's aimed at. High intensity ultrasound does create the deep heat. It'll create more cavitation, which the ultrasound wave goes down. Ultrasound is sound, and it actually just pushes tissue to the side. That opens up cavities. And that cavities allow more of a flow into the interstitial spaces or from the interstitial spaces, but allows that tissue to be, or that fluid to be more mobile, so you can actually move it better. Definitely cavitation may be one of the reasons why the tissue softens up a lot, and the reason why we see better local perfusion of the area and things like that following ultrasound. With wounds, if I see a real cyanotic wound, I will actually want to put ultrasound on the wound bed itself and deliver it to it. After about 2 to 3 minutes, you start seeing that tissue going from more of a blue to cyanotic blue to purple color, coming back to more of a reddish color to it. And what you've done is allow the waste products to start getting out of the area and the deoxygenated blood to get out of the area. Ultrasound also would affect things like calcium a lot. It'll break up calcium deposits. Like myositis ossificans goes to a calcium deposit. And I've had pretty good luck using, like if they have a small focal myositis ossificans, I'd like to see it on an x-ray first so I know where it is. And I could hit ultrasound from, say, anterior posterior and then medial to lateral, so I hit it twice. But I'm focusing right on that calcium deposit. And it really acts like little hammers and breaks up some of the calcium. And it's a good way to treat that when you have a mature myositis ossificans. If you did it in like a hematoma, on the other hand, you're probably going to cause more bleeding in the area and a larger hematoma by it. So you have to wait until it's really down to the calcium deposit. You could use diagnostic ultrasound in the area, and if you see a lot of fluid collection around it, I probably wouldn't want to do the ultrasound at that point. But once I have this calcium deposit in the middle of like muscle tissue, I mean, quads are great for getting myositis ossificans. I want to make sure it's mature enough so I don't cause a greater hematoma, but I break up the calcium deposit. Remember, I had one TBI patient that also had an open fracture of his femur from the car accident, and obviously they're looking at the head injury more than they are the femur. Initially, they probably would set the femur that much, but there was a lot of bleeding into the muscle bellies and a lot of hematoma there originally. I saw him about year and a half post injury. He basically had almost no, his quad was, if you feel it, it just felt like a rock, all loaded up with calcium. And obviously you can't get range of motion out of that. So we did little 5x5 areas, probably totally about an hour of ultrasound, doing each 5x5 centimeter area. Within a month, I gained back knee flexion to about, because he was stuck at about -70, I gained full extension and about 95 degrees flexion in the knee at that point. And I just kept going, trying to get more flexion. So we kept that treatment up for quite a while. And we do the ultrasound treatment and then do some stretching, things like that. But I wanted to break that calcium all up in there, and actually got a really good result. The guy was able to walk again and things like that afterwards. Was able to bend the knee enough. We got over 120 degrees of knee flexion, so he could get up and down from a chair and things like that independently. There are some books that say you should only do ultrasound for 2 weeks. To a joint capsule, I'll agree with that. But there's other reasons for doing as well, like the calcium deposit, which you'd want to keep going until the calcium's out of there. I would use high-intensity ultrasound because I really want to get a lot of cavitation going on. I really want to get that calcium just hammered with the ultrasonic waves a lot, break it up more. So we probably did it. I think we treated him with ultrasound like a month and a half daily. Cavitation just pushes the cells to the side. If you push them too hard, you could cause lysis. These could burst open if there's too much pressure there. But generally, with our clinical parameters of ultrasound, you're not going to do that. With generators that could generate a lot higher intensity, you could. And the higher intensity is going to cause maybe a little bit deeper cavitation, definitely going to cause a larger cavity to form. Then a low intensity will cause a little bit of cavity to form, but not that much. But this is why really ultrasound softens the tissue up and allows better cellular transport, because now I've opened up a lot of the interstitial space for fluid to go into and out of. And I've gotten the fluid more mobile. It's not being encapsulated as much and being retained in the interstitial spaces as easily. So cavitation may be the reason, one of the major reasons ultrasound really works. The thermal effect is vibration of different, maybe the interfaces between tissue. You only see it at high intensity ultrasound, which is over 1.5 watts per centimeter squared. And it'll give you a little bit of pain reduction that won't last very long, but 20 minutes is a good length of time to get another treatment in. You're also causing probably greater cavitation with this as well, so better intercellular transport and things like that within the tissue. And that actually helps tissue grow better too. Got better transport, you're getting more oxygen, the body can deliver more oxygen to the tissue easier, and nutrients as well. Acoustic streaming. Phonophoresis is based on this, where you put a substance you want to push in through the skin at the surface. Then the ultrasound beam is over that. Now, whether you're really pushing it in or you're just making this area more permeable to allow diffusion of the drug down deeper into the cavity you're creating, that's probably more likely what's happening. There's no way to really test this to be able to see what's happening, except there's no way to directly see it. You can indirectly see it. The drug, to be able to do phonophoresis, ionophoresis the same way. Lower concentrations of the drug tend to get through the epidermal layer better and into that capillary bed. If your concentration's too high, the capillary bed is going to go into vasoconstriction because the body feels like it's getting invaded with a very high concentration of medication. So if you block off the capillary bed, you really don't get the drug being delivered into the body. Lower concentrations work better, and they diffuse better. And that's in agreement with research that was done developing like the nitroglycerin patch and all the patch-type medications. And there's several of them out there. I mean, even to deliver nicotine or things like that. The concentration needs to be fairly low to be able to get through. If you want to get more drug through, you simply do it for a longer period of time or do it over a larger surface area. That'll get you more drug through the skin and into the body itself. There's several studies done on delivery of hydrocortisone through the skin transdermally using phonophoresis. And they found if they used like 10% hydrocortisone, did a phonophoresis treatment over it, measured the blood level of hydrocortisone pre pre and post, they found really not much increase in the hydrocortisone level post-treatment, but if you use 1% to 0.5% hydrocortisone, you actually see a significant increase in the blood level of hydrocortisone post-treatment. Again, it's that concentration thing, because at high concentrations, body feels like it's getting invaded, shuts down the capillary bed, so nothing's absorbed, or a lot less is absorbed. The hole or the cavity may be a way for this drug to be deposited down deeper in the tissue. So again, cavitation may be one of the major reasons why phonophoresis actually works. Now, I could probably deliver that same amount of hydrocortisone if I just put like the hydrocortisone a little opsite over it, over the skin, and I touch it with hydrocortisone, but leave it on for a longer period of time. You'll have diffusion through the skin of the hydrocortisone as well, but it doesn't have the cavity necessarily to go into. So it doesn't really increase that level quite as quickly as using a phonophoresis technique. Differences between high and low intensity. Now, low intensity may decrease calcium forming, but the high intensity is probably better to break up the calcium that's already formed. Low intensity, not going to cause a lot of swelling because you're not causing any deep heat. So you're not going to really increase the hematoma. So you could start off doing a low intensity of treatment when the hematoma is still there and present, and the calcium is just starting to form, and it may prevent you from forming a large calcium deposit to begin with. High intensity would be great to break up that calcium deposit. Heat increases the local metabolism. You're also getting the heat that's going to cause more perspiration. You get stimulation of histamine-like substances that cause more vasodilation in the area as well. You do get vasoconstriction initially in the deeper tissues, but then that's going to be followed by vasodilation once the hormones kick in. It will help you relax the muscle. Really good to do before myofascial release or cross-fiber massage or stretching. You do get some mild sedation with it. It'll slow the nerve conduction velocity a little bit, but won't last very long. We're talking really probably 20 minutes there. Low intensity, going to last a lot longer as far as the pain control goes. And that nerve conduction velocity is reduced for 4 to 8 hours usually after low intensity treatment, but you don't get as much cavitation. Increasing the circulation you get with the higher intensity. If you have a tumor in the area, metastases in the area, you're likely to maybe even cause metastases to spread. You're also going to cause more nutrition to the tumor, which is going to cause the tumor to grow a lot faster. So you really don't want to use high-intensity ultrasound anywhere where you think you might have a tumor. And I think as a cancer, you don't want to spread it. That's one of the primary things you don't want to do. So you want to be careful, but the cancers in that local area, certain cancers tend to spread certain directions depending on the type of cancer. Like prostate cancer goes to the pelvis and the low back. That's its primary spread. Breast cancer goes from really the lymph nodes in the pectoral area, but that can spread to the shoulder, it can spread to the cervical spine, maybe the thoracic spine, and up into the brain. So you don't really want to spread it. So you wouldn't want to do high intensity. Low intensity, I might be able to get away with, particularly if a patient's like terminal but really painful. A low intensity ultrasound may be a valid treatment there to decrease the pain, allow the patient some better function, at least for a while. You don't increase the circulation in the area that much or the perfusion in the area, so you're not going to spread the cancer as easily. You may cause, if there's a local tumor, it may grow more, but it's not going to throw metastases off either. Using the transmission medium. Oil, one of the ones that was used way back. We don't reuse mineral oil much anymore, but because it just runs away from you and doesn't stay in the local area that much. The gels are much better for that, but they transmit the ultrasonic energy. And oils and those gels retransmit probably the both. Now, it should be sort of a clear gel, maybe bluish in color. Those ones most aquasonic is probably one of the most commonly used. It stays in place good. You have good contact between the sound head and and the skin surface, eliminating mostly air gaps and things like that, because air resists the ultrasound wave and doesn't transmit it through it at all. So those type of gels are good. White lotions and things like that, the whiteness is from air bubbles, so it's not going to transmit the ultrasound. A more clear type transmission medium is always better. There's an underwater technique that was used a lot before we developed the 3 centimeter or the 3 megahertz sound head, and you wanted to hold your ultrasound, you put them in water. Water should be degassed. And if you just let water, actually my old modality book from probably written in the late 70s got really into this. Modalities were a big thing up until really about 95 or so. But we started questioning modalities late 80s, early 90s in their effectiveness. Then we had a lot of research studies saying how damaging modalities could be, and those were done for more of political reasons than they were for actually scientific investigation. We used to get paid also based on how expensive the equipment we used on the patient. Reimbursement was not based on how much therapist time was put into the patient, but what equipment you actually used up until 95. So that's how you priced your treatment, was based on the equipment, and the cost of your facility and things like that all went into determining that cost and what you could charge for something. Nowadays, it's really biased towards how much time the therapist is putting into it. What equipment they use really doesn't make any difference. And partly that's because our salaries have gone up a lot. And our salaries are a major part of is probably the major part of the cost right now. It used to be the equipment was more the major part of the cost, because I think the first job I had as a PT, my salary was $15 an hour, which is actually a good price at that point in 85. Now we see somewhere in the $50 an hour to $100 an hour salary coming from a therapist. Even some PTAs in certain areas. If you're out in the rural areas in Podunk where they can't find any PTs and PTAs, salaries are actually higher because they need to attract people to there. You hold the sound head underneath the water between 0.25 and 0.5 inches away from the skin surface. If it's right on the skin, it'll trap air bubbles between the skin and the sound head and not transmit a lot of energy. If you pull back just a little bit, the ultrasonic wave will go around some of those bubbles and actually produce more of the ultrasonic effect. And we used to do underwater for like hands and feet before we had the 3 megahertz head. When using a 3 megahertz head, you're trying to get a finger tendon or something like that that's really superficial. And they're usually fairly small diameter heads too, because you're trying to get the whole head in contact with the surface area of the skin. Now they do make a 3 megahertz head at a 1 centimeter or 1.5 centimeter diameter as well. They're rare. You don't see them very often, but they were producing sound heads of that size. Again, less penetration, but you're covering a larger area, so it's made more for a flat surface of the body, like the back and the buttocks and the quad and things like that. You wouldn't want to use something like that over a finger or a finger tendon or something like that. You got a moving or constant, and you're moving the sound head, and really the sound head's always on, so that's what the constant's about. Usually a 5 by 5 centimeter area. I have no idea why that's true. It was just convention that's been used since probably the 30s or 40s when ultrasound was developed. No studies saying what size of area out there that I've ever seen, and I've looked for them. High intensity ultrasound, more likely delivered this way. Stationary technique, you need to pulse it, so you're not going to get into high intensity anyway, because you want to prevent that standing wave. See the ultrasound wave coming down, reflecting back up, distributing the energy closer and closer to the surface to the point you're right at the bottom of the sound head, and you can actually cause a thermal burn there. So you need to pulse it. And a 1-to-1 is it's on for one, it's off for one. So you have a duty cycle there. Ultrasound really only affects what's aimed at. Doesn't affect the whole body. It will increase the growth of tumors or neoplastic tissue, which can be bad news. It depends where the patient is. If they're terminal cancer and you want to relieve pain to allow better function, And sort of a clinical decision is if the pain and function is more important than the tumor growth, I would probably go ahead and use a low intensity ultrasound and decrease the pain level. You don't want to do it over growth plates because it may cause that growth plate to mature prematurely. That stops the bone from growing in length. Now, if you do it over the diaphysis of the bone, like a long bone, no problem. There's no growth plate there. But you don't want to do it over the growth plate. You also don't want to do it over a fracture because it's going to vibrate all the little fragments in the fracture and cause a lot of irritation as well. And sometimes you maybe, say, ultrasound their back or something, they have a spondylosis, which is a fracture of the pars articularis, and they'll go yipe as you go right over that one spot. And I've found a few spondylitis doing that. Then I refer the patient for an X-ray. I want an oblique view, which looks at the pars articularis the best. You may see a Scotty dog, which is typical type representation of a fracture of the pars articularis there. So you may find a fracture that way. An old way of finding fractures before X-ray was around was taking a tuning fork, putting it across the bone, and the patient would feel exactly where the fracture is because that vibration would come down and really irritate the periosteum in the area of the fracture and move the little fracture fragments and really cause a focal pain there. So it was a way to find out where fractures were before we had X-ray. And you could still use it. Vibrating the fragments a little bit as a test probably isn't going to affect the healing or anything like that. So you still could legitimately use that. I know some doctors still use that in their offices. And if they get a positive result with the tuning fork, that would be a good indication they need an X-ray. And even it would pick up things like stress fractures that may not show up on X-ray, at least initially. They'll show up 10 to 14 days later when you can see the callus that's being formed from the fracture as the bone's starting to heal. Cavitation over the spinal cord, yeah, that could cause cavitation inside the cord, which you really don't want to do, or cavitation in the nerve root. But the cord itself and the nerve root is pretty well protected by the vertebral arches and things like that. So the amount of ultrasound you're actually delivering to the cord may be next to nothing. It acts like a shield to the ultrasonic energy. I think we went over phonophoresis pretty good. Primarily in the clinic, we use it like lidocaine, which is also called Novocaine. That's to anesthetize an area, and you can use phonophoresis for that. We don't very often. Steroid medication, probably the most common use. And it's going to drive, or not really drive, but it allows better diffusion of the hydrocortisone through the skin, particularly if you have a low concentration of drug. You can use a stationary technique if you're trying to get really one little small area, but you're going to have to use low intensity, so you're not going to create great cavitation. Higher intensity ultrasound going to produce better cavities for that drug to be deposited in, and that's usually better. Electrical stimulation, we can do a lot with it. And some things we can look at and set would be the current type. That often has to do with the stimulator itself. Some are alternating current, some are direct current. Alternating current can be called faradic, and direct current can be called galvanic as well. Those terms may show up on the exam, both in the PT and PTA questions. The frequency makes the tissue respond differently. You get different physiological effects based on the frequency. And there's something called tetany, which is about 50 hertz. Above 50 hertz, you get more of a static contraction with a lot of accommodation, so you don't get a very firm contraction. It's usually used more for inhibition techniques. 80 to 120 hertz is probably the most common there, which would be considered high frequency. Below 40 hertz, you start getting intermittent contraction going on, which pumps. And it'll actually increase the blood flow to the area and the flow away from, and the venous and lymphatic flow away from the area. 10 hertz, going to have better pumping power than 40 hertz. There's less accommodation happening, so you get a firmer contraction and a firmer letting go. 40 hertz, you get a little bit of contraction and a little bit of letting go, but not as firm because more accommodation is happening. In other words, more sodium may be coming out of the cells along with it going into the cell at the same time, and potassium the same way. So you don't get as firm of a contraction. Your electrode placement can make a lot of difference. If I have a target tissue, I could do cross that and put the target tissue, say, where the two envelopes of electrical stimulation are hitting, because you got a positive and a negative pole, and you got sort of an envelope between that that has the highest current density. And if I did it with a crossed, I could put high current density one direction and then put the other one, and where the two meet, I definitely have an increase in current density, which is going to cause more of an effect. An electrode placement can mean a lot. Sometimes you use a small electrode and a large electrode called a dispersive. Small electrode would be called the active. You got the same current really flowing through both of the electrodes, but if it's larger, it's dispersed more over a larger surface area. So you're not going to see as much of an effect there. The smaller one, you see most of the effect. And like with direct current, you can select either a positive polarity or a negative polarity of your active electrode. Your dispersive would be the opposite. So if I have a positive active electrode, my dispersive would be negative. Or if my active electrode is negative, my dispersive would be positive. And they're usually much larger. If you ever used a high galvanic machine, they have this about 12 inches by 12 inch electrode that's your dispersive. And you can select the wave form. Waves that suddenly increase intensity a lot and then shut off a lot, they're going to have the least accommodation to them. If you have an intensity that slowly increases, you're going to have more accommodation to it. So the waveforms can vary a lot. Like a sinusoidal, it gradually increases, gradually decreases, maybe goes across the isoelectric line into the other side of it. That's used with alternating current. Interferential is primarily a sinusoidal waveform that we use. And yeah, you get some muscle contraction, but you also get a lot of accommodation occurring, which would actually relax the muscle more, and you won't get as much of a pumping effect or as much of a strengthening effect. If you want to get a lot of motor units responding, you really want to have a very sudden increase in the intensity. So you'd use almost a straight up and down type current package, which we see in Russian stems. Here I would have two electrodes. My highest current density is between those two electrodes. But some of this is going to go throughout the whole body and come back as well. So whenever you put an electrical stimulator on somebody, their whole body is really within the current, and it has some current effect, but most of the effect is going to be the area of the highest current density, which would be right between the envelope between the two electrodes. The further apart you get them, the deeper you go into the tissue. But if I put them really far apart, I'm also going to get a lot going through the body and coming back to the other side as well. If they're really close together, I'm not going to get very deep. So how you set up your electrodes can really change the effect of your electrical stem. The whole body is in that circuit. Theoretically, it could affect like a patient with a pacemaker and things like that, because the pacemaker may pick up the electrical current frequency instead of the heart frequency, more confuse it, and it may turn the pacemaker on when it shouldn't be on. In practice, that really, unless you're going across the chest, which you should never go across the heart with electrical stem anyway, because of the effect on the heart, and it could alter the heart rhythm theoretically. But if I did like a TENS unit in the upper neck or the lower leg or the hands or the lower arm, I'm probably not going to affect the heart at all. And there's some studies that looked at it clinically, and they really didn't see any change in the EKG and things like that when you put the electrical stem on. Two areas fairly distal from the heart, where that area had the highest current density. It can start labor. So somebody who's pregnant, you really don't want to use electrical stimulation during the pregnancy itself. Now, once labor starts, you can use electrical stim. And I developed a program when I was the director of a hospital where we started electrical stim over the low back because, number one, moms usually have a lot of back pain. Number two, the uterus attaches to L1, 2, 3. So you get a lot of conduction of some of that electricity directly into the uterus, which causes the uterine muscle to contract more and contract a lot faster. Delivery times or the length of labor was actually cut in half in most patients at least a third drop in the length of time of labor if you use the electrical stim. And the faster the child goes through labor, the less compression in the vaginal canal, the less chances of things like CP and things like that. That risk goes down considerably. Prolonged labor, it can really cause it and cause anoxia of the brain, which is producing, at least what we think produces most of the CP problems, because the baby's being compressed for a considerable period of time. So not only do you shorten the labor, you can also use a frequency to cut the pain a little bit. Maybe like I used interferential units, and I would scan like 10 to 40 hertz to increase the circulation of the muscles in the low back. That decreases the buildup of waste products there, so they're not getting a lot of lactic acid type pain from it. And then do a high frequency to cut the pain level down and slow the nerve conduction velocity. So it actually makes the labor a lot more comfortable on the mom as well. To be honest with you, it was really easy to sell to the OBGYNs. And it was pretty easy to sell to the mom saying, I'll cut your labor time maybe in half, or definitely reduce it significantly. Sort of like, where do I sign up for this? It was really well received on both ends. And as far as I know of, as of checking about a year ago, the hospital is still using that program. Electrical stim primarily affects the type 2B muscle. They're recruited first, which are your anaerobic fibers, the 2A second, and the type 1 third. So it has a reverse recruitment order from normal volitional movement, because volitional movement, you start with the type 1 muscle fiber, then you add the type 2A and 2B to it in that order. So it reverses that. You probably could not do good aerobic conditioning using electrical stim, or great aerobic conditioning. You can do some, but electrical stim alone probably is not enough. If you had electrical stim tied up to a small computer that would sequence the muscles firing in the right order to pump to maybe pedal a bicycle or something like that, and you could have resistance on the flywheel of the bicycle, that's going to give you a lot more effect. But remember, when you're doing that, you're really exercising the muscles. One thing we've found out that patients that did the electrical stim, like C5 quads and things like that, even the lower extremity, after about a year, they gained about 70% increase in nerve conduction velocity below the level of lesion. That's probably increasing the plasticity, actually, and the nerve tracts regrowing, and about a 5 to 10% increase in EMG activity. And if you keep it up long enough, you may actually get to a functional muscle back again. But we're talking maybe 5-10 years before you'd really see that. So that's not really that practical. We do not know how much or the frequency of treatment that's needed to actually cause this, partly due to the subjects we had in the study. They sort of came in two flavors. One that just wouldn't do anything, would be fairly non-compliant, so they didn't gain anything. And the other group that you just couldn't get them off the electrical stim and bicycle. Christopher Reeve was somebody that would get on the bike at 8 o'clock in the morning, stop for lunch for about 15 minutes or 20 minutes, get right back on it again, and go to about 8 o'clock at night. And we had a lot of patients in that category who signed up for the study. We didn't get too many non-compliant patients signing up for the study, but we did get some, I would consider, overly compliant patients. Thus, you can't really tell how much you need to actually gain certain effects. Originally, we thought it would increase the circulation in the area, decrease the risk of DVT, decrease the risk of decubitus ulcers because you have better local circulation to the muscles that are paralyzed. That we initially thought. It would also reduce spasticity too, because you're really exercising aerobically and you are getting to some of the type 1 fibers, at least eventually. And spasticity is primarily your type 1 aerobic fiber. It's not the anaerobic fibers. Like if I have my electrodes, my positive pole here, my negative pole here, the highest density is between those two. Then there's lower density that goes throughout the whole body. That lower density area could cause seizure if a patient's about ready to have a seizure. It may take them over that threshold. It may start stimulating labor in somebody who's pregnant. Those are probably the two big problems you see, but most of my effect is going to be in this high density area. And if I would say have two pairs of electrodes crisscrossing where they intersect, I have much higher density. And interferential is sort of based on that. they say there's interference happening with interferential because one's at 4100 hertz, the other one's at 4000 hertz, and they say that sets up like a harmonic in the tissue or not. That would be almost impossible to prove. I can definitely see the area getting a higher current density. That's pretty easy to see, and to me that's more likely what's happening, but textbooks refer to that harmonic thing too. Alternating current, the poles are shifting between positive and negative, and a positive pole is called an anode, a negative pole is called a cathode. You may see that terminology on the exam. I use positive and negative, but some reference sources are going to use anode and cathode instead to really indicate the same thing. It's more of a grabbing sensation. You feel the electricity grabbing you more with faradic, particularly high voltage faradic current like an interferential unit produces or Russian stimulation produces. Female and male are a little bit different because females have generally a little bit thicker body fat layer over things, and fat resists electrical current and really sort of irritates things more, so they tolerate less amplitude. Males tend to tolerate a higher amplitude, and actually children don't have much of a fat layer at all, so they get the effect of the electrical current fairly easily without a lot of the buzzing and that burning, tingling type sensation as much. There are several studies that were saying that using TENS units and electrical stim may be a better way to address pain in younger children, really up through their teenage years, than it would be even in adults, maybe more effective. If it goes directly across the myocardium, you can actually stop the heart or things like that and cause a very serious situation. So you don't want to go across the heart. There'll be a wire going into the heart from a pacemaker that'll conduct that electrical stim too. So as long as a pacemaker in, I really don't want to do the left shoulder because the pacemaker's underlying that area, and a lot of my electrical stim is going to be conducted down into the heart through the wires that you normally put in to have the electrode that stimulates the heart of the pacemaker. It can affect the phrenic nerve as well, which can affect your breathing. Electrical burns can occur if you use more than 250 microamps because the intensity of the current itself, a lot of it is going to be absorbed by fat tissue and things like that and start to cause the fat tissue to heat up to the point you burn somebody below their surface. Since it's switching between positive and negative, you really aren't moving ions at all with faradic current or alternating current. With direct current, on the other hand, you are moving ions. If you put a positive over an area, you're going to draw negative ions to that area, which raises the local pH level. If you do a negative pole or a cathode over the area, you're going to draw more positive ions to the area and lower the pH. Body tends to tolerate the lower pH a lot better than the higher pH. Diabetes is a good example of that because the low pH is associated with ketoacidosis, and you don't get serious until you get about 500 milligrams per deciliter of glucose. You get symptomatic at about maybe 300, 250, 300 level, things like that. So the body's fairly tolerant of a more acidotic condition. Alkalytic condition, on the other hand, with the higher pH level, the body is very intolerant of, and it can cause a lot more tissue damage and things like that. Again, you don't want to use more than 1,000 volts, even in high voltage electrical stim. And really it's that pH that irritates the skin a lot in the area, and you can actually cause like an alkalytic burn that might be actually fairly deep just because you've raised the pH so much, and tissue is not very compliant with that. There's a lot of research done by the cosmetic industry that's showing to heal the skin up, more keep the skin younger, is products that have a relatively low pH to them do a better job of it. High pH does the opposite. So a lot of cosmetics are lower than normal pH. Like arm to arm's going to cross the heart. So your electrode placement does make a big difference. Alternating current generators, particularly high voltage alternating current, are usually wall units. They're usually plugged into the wall.
They're not portable. Interferential and Russian stimulators are the two most commonly used. Interferential, you're not going to get a lot of strengthening because you got a sinusoidal current, which tends to cause more accommodation. You can get a little bit of a pump from them because you are causing an intermittent contraction at lower frequency. Russian stimulators have the least amount of accommodation, thus the most facilitation. So you're getting more motor units responding with the Russian stim, at least to some extent. Direct current stimulators are usually portables. They're usually about the size of a pager or cell phone. They're usually battery operated. They really are low voltage usually. But there's also the high pulse galvanic stimulators as well, where most of the current is in one polarity, but then it'll suddenly slip a little bit to the other side of the isoelectric line to disperse some of the ions that are building up in there. A constant stimulation direct current where you have just plus on all the time or minus on all the time directly over the substance you want transmitted in the body. This is ionophoresis. And you do have to know the ion, if it's positive or negative, because the electricity actually repels the drug in through the skin, increasing the permeability of it, and draws it to the indifferent or dispersive electrode. So you can actually directionally sort of tell the drug where to go to by how you place your electrodes. High frequency versus low frequency, 80 to 120, it actually affects more the unmyelinated nerves because the myelin sheath is a fat and it prevents the electricity from really having as much of an effect. So 80 to 120, you have really a constant contraction, if anything, but a lot of accommodation, so you don't really get a forceful contraction whatsoever. If you really crank the intensity up, you get them to contract, but usually patients won't tolerate that type of intensity level. So we usually use 80 to 120, and you cannot palpate a contraction. Working on the free nerve endings, it'll decrease somebody's pain level about one notch or about one level, but it decreases the pain level a little bit through the gate control theory. TENS units are really made to be left on all the time. You actually should be distributing or renting a TENS unit to a patient when they need it. A TENS unit treatment, like they come in to orthopedic clinic and they get a 20-minute TENS unit, that's probably going to have very little effect whatsoever. And most insurance companies will deny that. But if you rent them the TENS unit or sell them the TENS unit and they're wearing it like all day long, all night long, things like that, that knocks their pain level down about one notch. That might allow them to sleep more comfortably and things like that, which would be important because we've got to sleep to be able to heal. Why we have to sleep to heal, I do not know. And there's been some research on that, and they don't know either. We don't really know truly what the effect of sleep is, other than you need to have it. Low frequency, 40 to 10 hertz, or pulses per second, is used a lot. Then you get an intermittent muscle contraction. 10 hertz is going to pump a lot better than 40, but you're going to feel it a lot more. 40 hertz, you don't feel it as much because there is more accommodation occurring, so it's not as firm of a contraction going on due to that accommodation. There's also very low frequency, and I've used this fairly successfully in patients, and you pick on a muscle group that isn't going to impair somebody's function if you overuse the muscle. You also want to pick a muscle group that maybe the patient can get to and attach the electrodes themselves pretty easily. They do about a 20 to 30 minute treatment of low intensity, maybe 2 to 3 times a day. Even once a day is going to be fairly effective. 2 to 3 times a day would be more effective. But if you overuse a muscle, that's going to cause endorphins to be produced within the body. Endorphins are endogenous opiates, and they fill the opiate receptors. They really decrease your pain levels, sort of like giving them a shot of morphine. And it can be equal to that. I've used it a fair amount with terminal cancer patients, for instance, and really dropped their opiate usage. Endogenous opiates, they don't confuse us like morphine would do. I think morphine almost makes you not concentrate on the pain as much instead of relieving the pain. The endogenous opiates would not affect that. I've had very success with fibromyositis and things like that because actually the pharmaceutical treatment for fibromyalgia is an opiate anyway. So the endogenous opiates have less side effects to them. You do get hooked on it the same way you would get hooked on an opiate.
but you don't have a lot of the side effects of going on. It won't suppress the respiratory rate and things like that, which opiates will do. So you don't have a lot of the negative connotations of the opiate. Fairly intense exercise, like 80, 85 to 95% of maximal, will also give you a lot of endogenous opiate production as well. And sometimes for fibromyalgia patients, they come in really sore, so they really won't be compliant with exercise. But I could set them up on this very low intensity electrical stim program, maybe have them do it 3 and 4 times a day, rent them a unit. You can do it with a TENS unit usually. You just set the parameters to this low frequency, and they do about 15, 20-minute treatment to a muscle group that are not necessarily going to need to use very much, but they can get to. And it's usually better with a superficial muscle and a smaller muscle, because a smaller muscle you can overuse easier, and that produces more endorphins. So you get their endorphin level up, their pain level starts going down, and then maybe you can transition them into exercise, and fairly high intensity exercise, to control it in the long run. And health-wise, if you're exercising consistently, that's great. And if they don't exercise, they feel a lack of the opiates and they want the opiates back again. So they have a tendency to be very compliant with the exercise at that point. You get patients really hooked on exercise, like a lot of runners. If they don't run for a day or a couple days, oh my God, even their mental status goes down the tubes, but their pain level would go up and things like that. So patients really get hooked on. Sometimes you got a marathoner or something like that you're treating, but you don't want them running. You're going to have one heck of a time to keep them from running. They'll just go limping around just to get their endorphins because they're really hooked on them. But you could get away with this low frequency electrical stim instead. I've also had patients hooked on narcotics as well, opiate narcotics, and you can run a low frequency electrical stim and then start looking at how much narcotic they're actually taking. And actually you'll see the level of morphine or narcotic that they're actually taking going down as the endorphin levels is coming up. And it's actually a way to get them off the opiate. And there are some studies showing really pretty good success rate with it. And then you can go from there to exercise and really change the patient's lifestyle. Precautions, seizures. If somebody is close to a seizure threshold, electrical stim can push them over that. If I have a patient with a history of seizures, I would like to see things like a digitalis level, or not digitalis, their anti-seizure medication levels to see if it's within the therapeutic window or not. If it's within the window, probably electrical stim's not going to cause a seizure. But if they're outside the window, particularly high, then their drug levels too low in their bloodstream, then you're more likely to cause a dilantin and phenatonin of the drugs I'm talking about, which you may see that those are probably the most common anti-seizure medications. So if they're really well controlled, they're not having any seizures, they maybe haven't had a seizure in quite a while, I could get away with electrical stim. But I'd like to see a blood test to make sure of that drug level first. It can stimulate labor. So if you don't want labor to happen, like in the first, second, or beginning of the third trimester, you would not want to use electrical stim. Once she goes into labor, then you could use electrical stim because it's going to cause a faster delivery. Even in the gut and things like that with the smooth muscle, sometimes crisscrossing the abdomen with electrical stim will increase the colonic motility more, prevent constipation. Something you do with a patient who is starting to develop constipation due to bed rest, but they can't get out of bed and they really can't exercise, you could electrically stim across them. One study that was done when I was in PT school on patients with post-abdominal surgery, they put electrical stim across the gut, and they found that bowel sounds returned in about half the time of normal. Usually once you operate on the abdominal area, open somebody up there, you slow up the colonic motility quite considerably. And it'll remain slow for about 5-7 days post before they start getting bowel sounds back. And you got to have good bowel sounds to be able to eat, because you got to make sure that the food fundus is moving through the gut and through the intestines. If it doesn't move, you build up a lot of gas pain and things like that. So some of the results of putting electricity across the abdomen in those patients was they had a lot less flatulence and a lot less gas pains, which is probably the most painful part of abdominal surgery, and eliminated that, or at least reduced it very significantly, and they got their bowel sounds back about half the time. Unfortunately, once you get your bowel sounds back and you start eating, the insurance companies want you out the door of the hospital. What we found out was the patients that had the electrical stim there, they were more mobile, they didn't hurt as much, and they were overdoing it. We saw a higher evisceration rate where the sutures would open up because the patient was being too active. So they decided not to go ahead with it after doing the pilot study, but the pilot really proved it worked. But for abdominal surgery, it's probably better to have 5 to 7 days to have the tissue start healing back together again before the patient gets too mobile. If they're mobile in 2 to 3 days post-op, you have a higher risk of evisceration, which means the gut opening up and the sutures opening up a lot because the patient's doing too much because they don't hurt. Pain's there to tell you to do something. Waveforms, continuous wave. I just go up in the positive and stay there, or go up into maybe the negative and stay there. That's the type of waveform you'd want to deliver an ionophoresis treatment because you want that constant polarity to pull the drug into the body. Interrupted, straight up and down. And you sort of see the straight up and down thing in like Russian stem. You have very little accommodation with this, so you're actually facilitating the muscle more, getting more motor units reacting to it. Sinusoidal has one frequency going here, like 4,000 hertz, another frequency going here, 4,100 hertz, and it causes a lot of accommodation being like this, so it would decrease more like the high intensity or the high frequency pain control, 80 to 120 hertz. Square wave, just up, hold for a certain length of time and let go. This being straight, I have very little accommodation. Spike waves, this is what Russian stem looks like. I have a carrier frequency of 2100 hertz, which is all these little lines, but then I have gaps in there. And how many of these bundles or trains are affected is your frequency actually. And you'd probably want somewhere between 10 and 20 hertz active frequency. High volt galvanic uses a pulsed wave where we're maybe in the plus for a while and then suddenly go in the negative. And this disperses some of the ions that are collecting around the electrodes. And it really prevents some skin damage. Now, high volt pulse galvanic is direct current, not as comfortable as interferential would be. Russian stem, very little accommodation, which means more facilitation. In other words, you're getting more motor units reacting to it. And theoretically, it may be better than FES, although some of the studies have shown there's maybe no significant difference between the two. Because if you put a Russian stem on somebody, but tell them don't do anything when you feel the electricity coming on, just let the electricity move the muscle by itself, no resistance on the muscle either, you can probably get somebody to about a fair with a Russian stem. You can also get somebody to fair with an FES unit as well, as long as they're not moving with it. And they're not trying to do a volitional contraction along with electrical stem. And then get somebody way above fair if they're also lifting weights and trying to do a volitional contraction along with the stimulator being on. Because the stimulator is going to recruit more and more motor units, particularly your type 2B or your strength fibers. And FES the same way. Russian stem may have a little bit more effect to it, but a Russian stimulator is plugged into the wall, so it's not portable. FESs are portable units. Modulation means changing the frequency. Interferential units, usually you can set a modulation where I may do like 20 hertz to get more pumping action going on in the muscle, getting better circulation, and then go up to 80 to 120, somewhere in that range, being set up in that frequency to decrease the pain by the gate control theory. And it'll flip from one to the other to one to the other, and actually gives a nice massaging effect to the patient and decreases their pain level fairly significantly. Now, if they're about ready to go into muscle spasm, electrical stimulation can trigger a muscle spasm too. So you don't want to do this on very acute patients usually. Subacute or chronic, it's better. The acute patients, you're likely to get into causing a tetanic contraction of the muscle, which is a muscle spasm. Burst means all of a sudden you get quite a few trains of electrical stim, then it'll shut down, and then you get another train. And low frequency electrical stim works well. This gets a lot of this of the endorphin production or the endogenous opiate production in the body. So bursting primarily is used for that. Pulse duration, which is how long the stimulator's on for muscle, 500 microseconds is better. To get the free nerve endings, the unmyelinated nerve endings, probably 200 microseconds is better. Here I have two different size electrodes. I have a positive or a larger electrode, which is called the dispersive, and I have an active electrode. So most of the contraction is going to occur underneath this active electrode because there's a higher current density there than there is here. This is one way to set them up where you have a dispersive and an active. The closer they are together, the more superficial. The farther they are apart, the deeper you get. But to be able to get a contraction and a higher current density, you'd really have to increase the intensity quite a bit. And there's only so much you can increase that intensity to, or the patient starts feeling it a lot because you're getting a lot of ion accumulation, or you're getting an electrical burn starting up in there if you're using alternating current. Direct current, you're going to get more of accumulation of electrolytes, like the positive pole, the anode, going to attract a lot of negative ions, which will raise the local pH level. And I wouldn't be surprised about something about pH on the exam. Bipolar, this is actually with the pregnancy, you may do this a lot. This would get a lot of the paraspinals and loosen them up, maybe make it a little bit more comfortable. But you could use a quadpolar too. I'd probably put L1, 2, 3 in the intersection between these two envelopes of electricity, getting my higher current density there, which will also transmit to the uterus itself better and speed up the delivery time, speed somebody through labor. But where they intersect, I definitely have a higher current density. I can do this with a high volt galvanic as well, just setting up my electrodes this way, or even a TENS unit. Intensity we often set to what the patient feels. Within the parameters, you don't want to go too high of intensity because you know that's going to cause damage. Sarah, you had a question? I unmuted you. Okay. Good night.
Good night.
No, that was just for Sarah because she said it was getting close to midnight and she was falling asleep. Children, electrical stim works well on kids, and I've used it in a lot of pediatric patients. They don't feel the nasty thing of the current as much. They actually get a better effect, and it really works well with them. There's a lot of studies out there supporting that. You got to watch out with kids sometimes with seizures, particularly CP. Quadriplegic CP usually has a lot of seizure problems with them. Hemiplegic, not so much. Diplegia, probably not at all. But they don't feel it. That's why little kids sometimes will stick wires into electrical socket. They don't really feel it all that much. They get burned, but they don't feel it. The only patients I haven't been able to use electrical stim with are electricians, because I think they can feel that current about 20 feet away. And they've gotten nailed so much in the past that if they just feel that tingling type thing happening, they just won't relax or anything with it. So I've really had failures of using electrical stim, really with electricians more than anything else. Muscle pumping, things like that. It's really the frequency you set it at really makes a big physiological difference as to what you're actually delivering to the patient and how you're changing the patient. Pulse duration is how long you're holding the intensity for. The amplitude is how high it is, and it's ramping up. Straighter, like straight up and down, you have very little accommodation. If it was way out here and a very slow ramp up, you would have a lot of accommodation, which means you don't get as much facilitation out of it. Usually the pulse duration in a duty cycle, you have a rest period. Rest period is usually twice as long as the pulse duration is. Now, with a really weak muscle, you don't have many more units responding to it initially, so you actually may have a very steep ramp up, a fairly short hold period of time, the pulse duration, but a fairly long recovery and rest time. Like instead of twice, you may have it 5 times the pulse duration. So that's what a duty cycle is all about. But it's a hold versus rest. This ramping down thing, I really don't see much in research that's saying one way or the other with it. In using it, I sort of get an eccentric type contraction here because they're starting to use less and less motor units. That's why they're getting more what looks like more of an eccentric, probably truly isn't. The ramping up, there are a lot of studies with that. If I ramp up fast, very little accommodation. Ramp up slow, a lot of accommodation. And if you're doing it for gait control theory or something like that, you want the accommodation. That's why you're doing it. On the other hand, if you're trying to strengthen a muscle up, you really don't want much accommodation. So here's just one suggested parameter for disc atrophy. The on time is 5 seconds. For moderate, the duty cycle is longer. So the time the electrical stimulator on is quite a bit longer in there. Probably rest is a little bit less as you see that change. So session length, they don't have much muscle responding. You'll overuse it fairly easily if there's severe atrophy. So the short, once you get into moderate or minimal, the times can actually increase quite a bit. And if you're doing like for minimal atrophy, you may do it 1 or 2 times a day. But initially, if you're doing very short treatment times, session lengths, you may need to do it more often. And like a 3 pulses per second or 3 hertz, I'm going to get a lot of facilitation, very little accommodation. 10, going to get more accommodation happening. Some of the drugs used for ionophoresis, dexamethasone is sort of weird. Actually, the ONs are steroids, and a lot of them are aliphatic, which means they're neither positive or negative. They just simply go with the flow. Since I get more results, more contraction of muscle groups and things like that, more stimulation of nerve with negative, I usually use a negative polarity over the drug. But if I want to put lidocaine with the dexamethasone, lidocaine is a positive ion, so I'd probably put a positive over it. If I put a negative over it, I wouldn't get much lidocaine. I'd still get the dexamethasone. There are some reference sources. I haven't put them in here, but they have had some questions on the exam. I'm pretty sure they were pretest questions that probably didn't make it through the pretest, but they would have how many milliamps. They would have the concentration of the drug you wanted to deliver. They would ask you how many milliamps do you set it at and for how long. Usually when I do an ionophoresis, I set the milliamps just below what the patient can feel. So I'll turn it up till they feel it and then turn it back a little bit so they don't feel it at all. I'll put the drug there, put the electrode over it, drive it in, and there's usually a med sheet that goes along with the ionophoresis drug. You can look it up and see how long you need to do the treatment session for to deliver so many milligrams of that drug. I think that's, to me, the better way of doing it. But they have asked questions that they give you a certain drug, you want to deliver so many milligrams, what milliamp do you use, and how long would you use it for to deliver that amount of drug. I don't think that's a good way of doing things. Novocaine, lidocaine used for trigger points. Whether or not trigger point therapy really does much or not, highly debatable. Okay, unmute yourselves. Any final questions?
No,
I'm
not.
good.
Did this help a lot?
Yes.
Yes.
You see that I'm attacking the modalities based on the physiology more. And that's the way they're going to go on the exam because that's where the evidence is. It's more on these physiological factors. That's why you select the parameters you want to select. And they will ask you they'll get picky on the parameters. With electrical stim, it's electrode placement, is AC or DC, and it's the frequency. The frequency probably is the most important factor because I can do 80 to 120 with a TENS unit, which is DC. I can do 80 to 120 with an interferential, which is an AC. Get relatively the same effect. May get a little bit better effect with the interferential, but I'm getting somewhat the same effect. On the other hand, use a TENS unit, they can wear 24/7, so you're constantly decreasing their pain level. And that one I would do probably over the damaged tissue if I'm doing 80 to 120. If I'm trying to get endorphin production to relieve their pain, then I want to put the electrodes away from that damaged tissue. Don't want to do it over damaged tissue at all. I want to pick on some other muscle group in the body. And it's probably best an area that the patient can actually get to easily on their own, be able to apply their own electrodes because it's an off and on treatment, like 20 minutes, 15 to 20 minutes, 3-4 times a day. trying to increase that endorphin level. So good luck. I hopefully this is helping you a little bit, making this a little bit clearer.
Yes.
But definitely they're coming from this physiological level here with the modalities, and the textbooks really don't bring it out too much. It's there, but you gotta go digging for it. And a lot of the textbooks written, say, 92, 93 to about 2003 or so, if they were developed in that time frame, they were sort of coming from a perspective that all modalities are bad, only manual therapy is good. And that theory did increase our salaries quite a bit and change the whole perspective. It caused a prospective payment system to be developed. So financially, it was a good boon to us. But right now, we use modalities to enhance our manual treatments of patients, and they make them more effective, although it really doesn't increase the reimbursement very significantly, but makes our treatments more effective. And effectiveness is what they're looking for on the exam, and it's actually a factor that Medicare is starting to look for too, because if your clinic is more effective, your patients are making larger gains, Medicare is feeling like they're getting more of a bang for their buck, they actually increase your reimbursement rate. It's about 20% differential right now. It's supposed to go up to a 75% differential, and that hasn't been affected. And God only knows what's going to happen with our reimbursement schemes. I've been on a couple committees, been on two of them throughout the years looking at reimbursement, and sort of what Trump's been pushing for is a cheaper but more effective healthcare system. It really is single payer. The single payer can, if you're the only person paying for medical things, you can say we're paying you so much and that's it. Even in the pharmaceutical industry, we're only paying so much for that Lasix. You can set parameters very much, and since everybody in the country is covered by it, if you don't agree with that, you're probably out of business. So that's probably the only way to get really cost constraint in it. Also a way to develop better treatment, because the data collected from a single payer system, everybody's going to be putting in the same way, they're getting the same type of data back, pair data very easily, and we can find out which treatments are more effective in what type of situations, doing multiple variant analysis. You can really mine that data really well. And that actually would improve both the diagnostic component and the intervention component of treatment throughout all of medicine. So our treatments would become more effective, our diagnostic will be more fine-tuned, we won't be repeating tests and repeating tests and repeating tests. You'll have better transfer of medical records and things like that as well with the single payer system. It's a way to have a good cost control. I don't think Bernie Sanders or people have really brought that point up, and it's not a death panel or anything like that. It would be a panel trying to find out which is the most effective. And it'd be a medical type community that's doing that. Right now, half the time it's an MBA deciding whether or not you get treatment or not from a private insurance company who has no medical background whatsoever, and they're just looking at the numbers. So trying to get us into a single payer system probably would improve the quality of care a lot and decrease the cost in care, which is what Trump was saying he wanted to do originally. So we'll see what happens. And I'm sort of hopeful a little bit, because the only legislation Trump's gotten through Congress has been something that he really started with the Democrats instead of the Republicans, which is sort of weird. Everything that was initiated with Republicans haven't gone through. But starting with the Democrats, he picked up some bipartisan support for things, and they got passed, like the debt ceiling and things like that very recently. So we'll see what happens here. But everything's up in flux right now. It's probably going to be, they're probably not going to address health care again this year. They probably will wait till the new Congress hits in January to even think about it. And since it's an election year, I doubt too many congressmen are even going to want to address it, because healthcare is an extremely important part of the voting population, very important to almost everybody. So have a good night, and if you have any questions, please call me. If you got the hint, I am feeling a fair amount better. I'm by far not perfect. I have downloaded your week for the PTAs. I've downloaded week 2 so far. I probably should have those posted sometime tomorrow. Then I'll do week 3 and week 4. I'm trying to get at least those first 4 weeks with all the papers done.
and I might be able to get the other weeks too, all the way through week 9, which I have a couple PTAs all the way through week 9. Ideally having that all done by Sunday, so at least you have some feedback to look at. When you look at papers being returned, look at your paper, but look at some of the other papers too. Because mistakes other students will make, maybe some mistakes you might make too. So good idea to look at things and look at the approach. I do write different comments to everybody, so I maybe missed something to you, but I caught it with somebody else. So work your way through those. Tomorrow night I do arrhythmias in more detail. So if you're on, I'll talk to you then. Friday is going to be safety and patient care and patient handling. That'll include things like IVs and dealing with chest tubes and dealing with catheters and things like that with patients, along with some electrical safety issues. So those are major safety areas. They do hit about maybe up to 7 or 8 questions over the exam. So it's worthwhile looking at. PTA actually has a higher percentage of those than the PT exam does. So I'll see you then.